here among you at the International Summer School of Orthodontics. And even Professor Speil introduced me. I will short introduction of my dental clinic where I work. I'm an associate professor at the Faculty of Dental Medicine at University San Siro and Methodius in Skopje, and also work in Dental Clinical Center as a head of the dental orthodontics clinics. President of Macedonian Orthodontic Society. Macedonian Orthodontic Society was established in 2005. I'm president in a second mandate from 2013. We are part of two big societies of orthodontics, World Federation of Orthodontics and European Federation of Orthodontics, and from the last year we, as a founded member, one of 8 founded member, is member of Balkan Association of Orthodontic Specialists. Everything you want to know about this, you can find at our website. You can see these 3 websites. The last third website is new, and it will be open at 1st of October. Now it's in construction, but you can see the first announcement there. As a president, I was president-elect, and now I'm president of Balkan Association. So we organized our 4th Congress, joined with 3rd Congress of Balkan Association next year in September, from 12 to 15 of September in Hotel Metropole in Ohrid. And you can see leaflet flyer for the first announcement we made in May. Now the list of invited speakers, keynotes and invited speakers is wider for these few months, and Professor Speil is also invited speaker, our guest and special guest and friend, of course. So
so we're going.
I wish every one of you to come in Ohrid because we really made a good preparation for the congresses. We already have two in the past 7-8 years, 3 congresses, 2 in Ohrid and 1 in Skopje. And I hope you will have a good scientific experience, but also social experience.
Even better.
Thank you. So I proceed with the lecture with about myofunctional approach in orthodontic therapy. And I start with first chapter in every textbook of orthodontics, growth and development, because the morphologic characteristic of the craniofacial complex, it's known that it's based on inheritance and genetics, but in function is very important too in morphologic characteristics. So craniofacial complex is a complex system composed by jaws, dentoalveolar structures, and orofacial muscles, which have to be in dynamic balance, and this equilibrium is very important for normal growth and development. Even the smallest changes can influence in dynamic balance. Even we don't think about that and we ignore that small changes, but it's true. From the birth of from our birth till we met the patient to make decision for orthodontic treatment. And in this brief introduction, I will mention 3 icons in orthodontics. One of them, all of you know, Edward Engel, who classified occlusion in sagittal dimensions. He, when he speak about malocclusion, he stated that malocclusion is an incorrect relation between the teeth of the 2 dental arches, not a simple misalignment of teeth, because we treat malocclusion not a disease, but we treat variation of normal growth and development. So he stated that soft tissue dysfunction are the driving force behind malocclusion. Next icon in orthodontics, Charles Tweed. I suppose many of you go to Tweed courses. You know that Charles Tweed is one of the great mechanical geniuses in orthodontics. Even that, I find one sentence in the chapter
Hajde otvori, stipe.
guidance of occlusion with emphasis on diagnosis. This is chapter in the Graver's book, Current Principle and Techniques. And he said, as we learn more about growth and its potential, the influences of function of the developing the tissue will acquire a better understanding when and how to intervene in the guidance of growth process, so that nature may better approximate her growth plan for the individual patient. And in the other words, knowledge will gradually replace harsh mechanics. Harsh mechanics, it's said by the greatest mechanical genius of all time. And in the not too distant future, the vast majority of orthodontic treatment will be carried out during the mixed dentition period of growth and development and before the difficult age of adolescence. And another icon, Rolf Frankel. Functional regulator. There's 4 types with 3 subtypes, and it's FR, functional regulator, but it's also the initials of Rolf Frankel. He is one of the leaders and start with something new in functional orthopedics because he changed the basic principles of activator, bionators. He used 3 basic principles through buccal shields and lip bumpers, application and elimination of the pressure, and also application of traction. So, in that way, he created a base for normal position and function of the tongue. Modern orthodontics these days recognize 2 opposing views. One are functionalists and other are mechanists. Functionalists believe that especially the functional matrix, especially the one of muscular nature, is the decisive principle of malocclusion. And the others, mechanists, advocates of the mechanical principles in orthodontics, and they say muscular dysfunction is the result of malocclusion, not opposite. I will go back for the growth and development. You know, the direction of the normal growth and development in children is downwards and forward. But to fulfill the full genetic potential, the tongue must be in correct position. The patient must breathe normally through their nose, not through their mouth. And in that way, there will be more space for the teeth, anterior and posterior teeth. Basically, on the theory of the functional matrix by Melville Moss, which is based on the principle that the individual facial growth and development is closely related to functional activity of various components of the head and neck. So the type of breathing, the breathing pattern is very important because nasal breathing allows proper growth and development of craniofacial complex, interacting with other functions like mastication and swallowing. As a previous said, malocclusion, it's with we are dealing in orthodontic, but it's not a disease. It's a variation of normal growth and development, and it occurs as a result of different factors. One of them are genetics, one are inherited or acquired, such as skeletal, soft tissue factors, dental or local, and combination of all. So if the growth journey is interrupted, development becomes more vertical than horizontal, and that means much less space for the teeth in the jaws. So we have focused on the soft tissue dysfunction when we start to plan the orthodontic treatment. It's very important to use the strength of the muscles from the lips, from the tongue, and the combination of these two muscles. Tongue is the most, I think, most heavier and powerful muscle in the human body. With force of 500 grams, the tongue muscles can expand the dental arch, especially maxillary dental arch, and in that way he creates a space for whole teeth in the dental arches. Imagine how if the position of the tongue is not in the correct place, how it can influence on the position on the incisors, maxillary and mandibular incisors. And of course, there are no effect on widening the dental arches. There are some cases. These pictures show different position of the tongue at mouth breathers, at children with worse type of swallowing, in creating narrow dental arches and crowding. The reciprocal action of the tongue and contracting of the lip and cheek muscle when swallowing can create a reverse swallowing pattern which causes crowding. If you want to ask something, please interrupt me and I will give the answer if I can explain. But I think I can proceed now?
Yeah.
Okay. My field of interest from the start when I started learning orthodontics, my master thesis and doctor thesis is about breathing pattern. so I focused on the respiratory function, and I shortly introduced the meaning of respiratory function across the airways, type of respiration, position of the head, hyoid bone, and mandibular. Respiratory function is one of the four basic functions in orofacial complex, and it is significant etiologic factor who affect the growth and development of craniofacial structures. Craniofacial structures composed by teeth, jaws, not only mandibula and maxilla, but nasomaxillary complex. Dentomaxillofacial complex is one single compact unit. And nasopharynx is integral part of that. So the type of respiration, the dimension of airways are so closely related and connected to the extent that we cannot look for the morphology itself and function itself, but cannot be analyzed separately. Anatomically, in pathophysiological condition, anatomically narrow airways represent predisposing factor of obstruction of the upper airways. Obstruction of upper airways forces the patient to breathe through the mouth. In oral respiration, the result is alteration of the forces affecting the craniofacial system and the skeleton. The mandibula is lowered. The position of the tongue is also lowered, spread in the mouth. The lips are incompetent. They are not anterior seal. The lower lip moves away from the labial surface of maxillary incisors, and the mandibula may not contact with maxilla during swallowing. So, permit the vertical, extremely vertical alveolar development and posterior tooth eruption. Adenoid facies, facies adenoides, is a typical face for mouth breathers, with open mouth posture, hypotonic lips, extreme compression of the maxillary dental arch, frequently mandibular retroglyphism, and increased anterior and especially increased lower facial height. Nasopharyngeal obstruction is one of the most frequent entities in the human pathology. Some of the children present with mouth breathing as an isolated manifestation, but others develop sleep-related breathing abnormalities. 20% of children exhibit habitual snoring, and 1% suffer from obstructive sleep apnea. There are two theories, one functional and other mechanic, how hypothetical theories for mechanism, how nasal obstruction may induce sleep-related abnormalities. According to the functional theory, upper airway obstruction can lead to apneas via disturbed reflex mechanism by nervus trigeminus or nervus vagus that normally act to preserve airway patency. Contributing factors may be poor tone of the pharynx and poor tone of tongue during sleep. Mechanical theory, according to mechanical theory, with the direct mechanical effect, with obstruction on narrowing the upper airway, the pressure gradient for airflow increase and the pressure within the upper airway become more negative to the atmospheric pressure. the position of the mandibula, the position of the tongue, the hyoid muscle, and the position of whole body and the head is the primary determinant for respiratory functional demands. Every change in mode of breathing affects the change in the position of the above mentioned head, hyoid bone, mandibula, and tongue. Based on the respiratory functional demands and physiological requirements for a major airway space, extension of the head will lift head away from the hyomandibular complex, and it, according to Ricketts, is a defensive compensatory functional mechanism that serves to maintain the capacity of nasopharyngeal airways. Such a change in a posture will increase the diameter of the airway and in that way facilitate the transition from nose to mouth breathing. The hypothesis of the existence of interaction with the position of the head, craniofacial morphology, nasorespiratory function, and the size and shape of airways were confirmed by many studies. Researchers generally agree that respiratory function affects the facial morphology and head posture. Some authors believe that the extension of the head can affect the dimension of nasopharyngeal airway. Changes in the position of the head and craniofacial angulation after different types of therapies was shown in Linder Aronson and Wenzel investigation. Linder Aronson investigated children with after adenoidectomy, and Wenzel investigated the children after with allergical rhinitis after pharmacological treatment with budesonide, and they found after that treatment a change in the position of the head and the body. But that means that craniocervical angulation decreased in that case. And this is angles. You can use these 60 angles to measure the position of the head in mouth breathers, but in the other patient too. There are two tangents, OPT and CVT, crossing through cervical second and fourth vertebra, and three lines, basic lines, plane of anterior cranial base, Frankfurt plane, and maxillary plane. And only a few words for a hyoid bone, which for me is very important, but most of the orthodontists don't recognize, don't know and recognize the importance of the position of the hyoid bone, and especially maxillofacial surgery. After third or fourth slide, you will see why I say this. Hyoid bone is a unique singular bone with no articulation. Not articulate with other bones, but depends on tension of muscles, ligaments, and fascia. Derived from mandibular cranium, cervical spine, clavicula, sternum, and elastic membranes of the larynx and trachea. It's supported by soft tissue, ligaments, and muscles, so it changes its position depending on the position of the body and the position of the head. Physiological movement changes its position in the course of various oral function combined with the tongue function. This bone positions about the level of lower mandibular border in early human life. but with age gradually descends to approximately fourth cervical vertebra. According to Adamidis and Spiropoulos, in their work, hyoid bone may be essential to maintaining the capacity of airways in the first years of child's life. Hyoid bone is associated with some vital function. Position of the hyoid bone controls the tongue function if its position is normal, related to the cervical column. Position of the hyoid bone and its muscles play a very important role in pharyngeal, in the dimensions on nasopharyngeal airway and capacity of that airway. And according to the literature, the stable hyocervical relations preserves the upper airway patency in adults. Extension of the head changed the position of the hyoid bone, caudally and distally. Changes in the position of the hyoid bone results in a change of the position of the mandibular too. And patients with retrorefusal, mandibular retrorefusal, hyoid bone is positioned posteriorly, and this position is directly related to narrowing the upper respiratory tract. So in class 2 we have position distally of the hyoid bone and closing the airway space, and opposite of that in class 3 we have bigger area space, but it is in the class 3 progenia vera, not in a pseudo progenia, because in pseudoprogenia it's not from the mandibular but from the hypoplastic underdeveloped maxilla. And in surgical cases, the maxillofacial surgeon have to think about the position of the hyoid bone when they do the surgeon in class 3, for example. Because in class 2, the orthodontist or surgeon move the mandibula forward, they create a more space for breathing. And opposite in class 3, there are enough space, but when they do the surgeon and shortening the length of the mandibula, they put the hyoid bone in distal position. So they close